Welcome to Indian Society of Toxicology. Today we will be discussing about a case who presented to our ER with complaints of bilateral vision loss. Can you begin, sir?
Yeah.
A 34-year-old male patient was brought to ER with complaints of bilateral painless vision loss since last 24 hours. Initial 10-second assessment, patient was conscious oriented and obeying commands. His airway was patent, there was no pulling of secretion and C-spine was normal. Breathing, his respiratory rate was 18 per minute and air entry was bilaterally equal with a saturation of 98% in room air, and his chest exertions were also normal. Circulation, his heart rate was 98 per minute and his blood pressure was 120 over 80 millimeters of mercury, and all peripheral pulses were felt equally and bilaterally. Disability, GCS was E4, V5, M6 and his pupils was 3.5 millimeter non-reactive. It was dilated and fixed and non-reactive, and there was some congestion was there in the eye. Some redness of the conjunctiva was there. And disability wise, he was telling that he is not able to perceive any light sensation to the eye and he is not able to see anything. There was no pain. Pain score was 0. Exposure, temperature was 98 degree Fahrenheit and GRBS was 110 milligrams per deciliter.
Okay.
At this point, we were thinking about multiple differential diagnosis, and since this patient is a young male who presented with bilateral vision loss, to rule out any toxicological causes, we asked for an ABG. ABG was showing a pH of 7.344, PCO2 of 36.8, bicarbonate of 19.5. So it is a metabolic acidosis in this ABG, and lactate was 0.8 with a creat of 0.74, and in this ABG there was an anion gap of only 1.5 was the only anion gap in this. So
Can you just go through the blood gas again? pH was
7.344.
344, almost normal.
PCO2 36.8.
36.8.
Bicarbonate 19.5.
So what is the expected PCO2 for this bicarbonate?
For this bicarbonate, I expected
It will be somewhere around 36 only. I think it will be
38
38 plus or minus 2, somewhere nearing to 36, 37. It is adequately compensated metabolic acidosis. Anion gap?
was only 1.5, sir.
Anion gap was only
Sorry, sir. Yeah.
1.5. What is the sodium?
Sodium, it's not mentioned, but it was 1.5.
1.5. Unlikely to be 1.5. So usually
We will be expecting a high anion.
it can be in high anion.
Yeah, such a low value is not to be expected.
Maybe some error in your calculation.
No, sir.
1.5 anion gap. Osmolar gap.
Osmolar gap was 8.
What is osmolar gap?
Osmolar gap is actually the calculated osmolarity subtracted by the serum osmolarity. So we calculate the osmolarity by 2 times the sodium plus glucose divided by 18 plus 1 divided by 2.8.
Okay. What is this 18 divided by 18? Glucose divided by 18. Why you wanted to do that?
Micromoles, molar,
Which one?
the molar.
The difference. That is the actual difference. If you get millimoles per liter, you want to convert 1 millimole of sugar into milligram per deciliter, you have to multiply by 18. So for calculating, you have to make it to millimoles. So we have to convert it to 18. That's the same stands for your blood urea nitrogens. So basically 2 into sodium plus glucose divided by 18 in milligram per deciliter plus blood urea nitrogen divided by 2.8 will give your calculated serum osmolarity. That is your calculated serum osmolarity. Then you have to send a lab for your serum osmolarity. Then the difference, what we call it as osmolar gap, and more than, when it is significant?
More than 10 is significant. In case of any alcohol intoxication or anything, it will be high.
Any toxic alcohol ingestion, it will be more than 10. Usually it will be less than 10, but usually in alcohol ingestions and all, it will be very high. It will be above 20, 25 and all. So why it is like that? What is the difference? What is happening in calculated? What is calculated in lab osmolarity?
like here in calculated osmolarity, we are taking into consideration only these three things: high osmolar substances like glucose, sodium, and urea. But in other things like toxicology, the other high osmolarity substances may be there, like the methanol, glycol, and all those. So that will be calculated in the lab value.
Lab value. So that is the difference why it is happening. So now we have a young male who has come with a painless visual loss. Now let's start from the beginning. Painless visual loss for 24 hours. So what will be the consideration? Differential diagnosis. We can start with unilateral, then we will go to bilateral. So unilateral visual loss, painless, painful. Now let's start with painless visual loss.
According to algorithm, when we are every patient comes, first we should ask for a history of trauma. If trauma is not there, then we will go to the one side of the algorithm. Then we have to see, if no trauma history, we have to ask whether there is a history of pain or not. If there is no pain, then either it can be because of a central cause or a local cause can be there. So either it can, if we are going to the local causes as such, then it can be either because of a in the local causes there can be lens dislocation can be there, or posterior uveitis without any pain, or any patient is taking any anticoagulant something and it spontaneously patient is developing a hyphema over there, or it can be because of vitreous hemorrhage. Some vitreous hemorrhage might not be having pain, then it can be central retinal artery occlusion or central venous occlusion can be there, or it can be an occipital coming to the posteriorly, it can be an it can be a chiasmal lesion or a retrochiasmal lesion. It can either involve the optic tract, or it can involve the occipital region, occipital area stroke can be.
Okay, so that is from your anterior chamber to the posterior chamber. You can have reasons for your starting from your anterior chamber to the occipital lobe. Anywhere you can have a lesion, and the patient can present with an unilateral visual loss. But when it goes behind, the presentation will be different. It will be because the field of affecting will be different. Maybe other side also will be affected. So exactly the patient might be complaining of a unilateral visual loss. So if it is optic chiasma is involved, it will be, what will be the type of...
if optic chiasma is involved, the patient will be having bitemporal vision loss will be there. So the nasal part he will be able to see the
bitemporal hemianopia because of the crossing of the fibers of the optic tract. So depending upon the lesion, the presentation, and but the patient will be able to say only he is having specifically regarding maybe whichever eye is affected more, he will be able to say. Sometimes he will be able to say both the eyes. If there is pain, then what will be the differentials?
If there is pain, it can be either because of trauma induced, and if non-traumatic causes, it can be because of some anterior uveitis or glaucoma can be there, and some optic neuritis can have pain, and
retinal detachment. Okay, then. What is the most common reason for visual loss in ED? Migraine. Again with pain will be migraine. They will be the classical thing is that ocular migraine, which is very, very, very notorious to cause the sudden visual loss. The patient maybe they will have some aura. Maybe they might not even have a headache also. They will be suddenly seeing their activity and suddenly there is a visual loss. And at that time, how will you differentiate? How will you diagnose it is due to migraine? It is not due to anything else. Because migraine is a very common entity in ED. The patient comes suddenly with visual loss. They are very...
Normal pupillary reflexes.
Normal pupillary reflexes, everything will be normal except for a color vision. That might be the only thing that you will be able to differentiate. Because you have to have an Ishihara chart and you have to look for the color vision. So color vision will be the only thing that might be affected. And the classical history maybe after 20 or 30 minutes, it will be starting with a blurring or a flutter. The classical history will be a blurring or a flutter, and suddenly there is a visual loss. Maybe unilateral, even bilateral visual loss is also possibility in migraine. It is not mandatory to have headache. Headache may be there or may not be there. So ocular migraine presentation is very, 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 very difficult. You have to convince the patient they will have multiple attacks. This episode can happen. It can suddenly happen. But usually they will have some triggers. Some triggers will be there in the background. And you need to have, definitely they need to have a detailed evaluation. You can just leave that alone and ask the patient to go. You need to have a detailed ophthalmology evaluation. And all the field, everything they should be doing, and the tract, everything they should be assessing. So that is regarding ocular migraine. It is one of the most common one that we can easily miss also. We will think something else, but after sometimes they will be okay. Then what will be the next most common? Elderly people, sudden visual loss, Amaroxys fugax. That is again, they'll just come with some blurring of eyes. They will not say visual loss exactly. They will say some visual loss, but after sometimes it has improved. So that is regarding your Amaroxys fugax. Okay, so right now we have a young male who has come to us with sudden onset of visual loss, bilateral visual loss, painless visual loss. So you think what will be the problem here? It's a bilateral issue. So bilateral issue, so where should be the problem?
Local causes cannot be a reason in this. So it can be either it can be in the optic nerve or behind the optic nerve in the brain.
Or there is something that is affecting, something that is causing damage to both the optic tract. Both the side of the optic tract, both sides is affected. So usually what will be the presentation in an optic neuritis or an glaucoma? It will be unilateral affecting. Glaucoma will be single eye will be usually affected. But this is a global issue because both the side it has got affected. So he is having bilateral visual loss and that too painless visual loss. So like this history, when we come, the most common differential will be what?
We have to consider some pathologies. That means both the optic nerves will be coming in the optic chiasma. So some chiasmal lesions. But
chiasmal lesions, it will not be a rapidly. It will be gradually increasing. So they will come with some field defects. They will have initially to start with some field effect, but the visual loss part will not, unless and until it's a sudden hemorrhage into the pituitary or something that is suddenly happening. But tumors and all, it will be a slowly growing tumor. Multiple sclerosis, that is one thing. Vasculitis, they can come with vasculitis is very common, and
papilledema, raised ICP, papilledema
press syndrome. That is again very commonly we have dealing in the ICU. The patient is admitted in our ICU and suddenly they are complaining of visual loss. And when you check their blood pressure, the blood pressure has gone up, and they even can have a seizure also. So that is press syndrome. So that is again, press syndrome is the posterior
reversible encephalopathy syndrome.
Encephalopathy syndrome affecting the occipital lobe. So that occipital lobe is affected, so the visual pathway is also affected. So that the pathway, whenever you are evaluating the patient, you should clearly know the pathway and which all structures is what all happening, we should understand. Otherwise, there is of no use. Then
remember that the press syndrome is more of a radiological diagnosis.
Yes,
Okay.
Or it can be something like toxins or something affecting a generalized.
yes. So which toxin?
Commonly seen as a methanol.
The common one is methanol toxicity. Now we don't have any history here because there is usually they will come with a history of ingestion of illicit alcohol. They had a party, they had gone out somewhere, or something will be there, or deliberate self-harm. Some history will be there, but here we don't have any history at this point of time. So we need to consider methanol as one of the differential. But what are the things that is against methanol now?
Now it is like a normal, like anion gap is very low.
Can we have a normal anion gap and just with visual loss?
Yes, sir. If the patient is consuming only like 10 ml of methanol, adult patient might be only having some vision problem. If he is taking more than 30 ml only, he might be having this metabolic acidosis, high anion gap.
So that is also a possibility. So he don't have much of a metabolic acidosis here. Only his problem is the visual loss. So it is something to do with bilateral. Right. That is the only thing that is we have no. Then coming to the examination, how will you evaluate this patient in your ED? What all ophthalmic examination that you need to do? Local examination, because there is nothing in the secondary survey to examine here. What are the things that you will do for eye examination?
Eye examination, in the eye we have to look whether the both corneas are clear or not. Then we have to look for the we might need the help of our colleagues from ophthalmology also. The anterior chamber should be.
So there is no ophthalmology. You are practicing alone. You are alone. No ophthalmologist available.
Pupillary reflex.
See, whenever you are planning for an ophthalmology examination, you should have a clear-cut idea what all things you need to evaluate. First of all, simple thing, inspection. Start with your inspection. From inspection, what all things you can say?
If, whether there is some redness over the conjunctiva.
There was some redness over the conjunctiva, what you have mentioned. Then
the cornea, whether there is an opacity of the cornea.
Above the cornea, there are other structures also.
sclera.
You have to say everything.
Lid
You have to
edema.
start from the lid. Any evidence of ptosis, any evidence of squint, movement, eyeball movement, that will come to later. Eyeball movement is very important. That is again one of the most important bedside examination that we need to do in. But in this patient, it is not possible because of the visual loss. And next thing, inspection you have done. And after inspection, what do we have to do? What is there in palpation?
Palpation, we have to check for the tension. Digital tonometry.
Digital tonometry can be done to look for your raised ocular pressure, but nothing to do in palpation, nothing to do in auscultation or percussion. So the next thing is your special test. Then the most important will be you have to do for eye movements. You have to look for all eye movements in all quadrants and field of vision in all quadrants. Field of vision in all quadrants. That is a very basic bedside examination, basic ophthalmologic examination. You have to ask for all the, if the patient is able to move the eyeballs up, down, laterally, medially, and below. Every quadrants you need to evaluate, and you need to evaluate for the field of vision also. That is the most important examination. Here it is not possible. Then coming to your special, that is a pupillary examination. You have to look for your
direct
pupillary reflex, direct
and
consensual reflex. Is corneal reflex part of this, or corneal reflex is done for something else? It is for?
Corneal reflex is for the sensations.
It is for trigeminal nerve. It has nothing to do with the ophthalmologic exam. It is for your trigeminal nerve. What you have to do is here pupillary reflex, direct and consensual. So how will you, from your pupillary reflex, how you can differentiate whether it is a local cause or it is a problem somewhere else? And pupillary size, again it is very important, whether it is myotic, mydriatic or mid-dilated. Differences, reason?
Myotic pupils can be that it can be because of the local pathologies or something affecting the sympathetic nerve. Then in alcohol, acute alcohol overdose, there can be meiosis. OP poisoning, meiosis can be there. Then in case of Fontaine hemorrhages and all, meiosis can be there. Then a mid-dilated pupil will be seen in case of acute glaucoma and all, mid-dilated pupil will be there. And dilated pupil can be seen in methanol poisoning and all. Then if there is any brainstem herniation or anything, we can see dilated.
Okay, so from pupillary reflex, so direct pupillary reflex. So I'm telling that there is no direct pupillary. You said what was the finding in this patient?
This patient, bilateral pupils were non-reactive.
Non-reactive. What could be the reason?
So in case of if we are lighting first
shining the
torch, first the afferent is the optic nerve, then the efferent is the oculomotor nerve. So if you are shining the torch and there is no direct reflex, that means something is affecting the afferent pathway. So optic nerve will be involved in that. And simultaneously, when there is a consensual reflex which is present, that means that the oculomotor is, the opposite optic is not.
No, just imagine for example, you have a pathology in the right optic nerve. You are shining the torch. What will happen?
Then bilateral
direct as well as consensual is absent. This eye is normal. This eye is normal. You are shining the torch here. What will happen?
Direct and both will be present.
Right.
Shining the torch, you have an afferent pathway. If that ocular motor nerve is also fine, you will have direct consensual. What will happen? It will also be present, because if the ocular motor nerve is on the other side is normal, it will also be present. Here both the side the optic nerve is affected. So there is no confusion. The afferent, whichever, you have to clearly know the pathway. Afferent is by your optic nerve, efferent is by your ocular motor nerve. So whichever is affected, that will be lost in your pupillary reflex. Fine. Okay. Now, what happened to this patient?
So sample history was asked. There was no allergies. He is not taking any medication, and there is no recent surgical history. He is an occasional alcoholic, and last alcohol intake was 1 month back. What history he gave was he felt diminished vision followed by some flashes. He was seeing some flashes, and after that he felt that his vision is progressively reducing, and it was painless, and at last he was completely blind. He was not able to see anything. He was taken to outside hospital and they took an MRI brain, which
This
was.
one, I think examination we missed out fundoscopy, right?
Yeah, fundoscopy, yes, definitely. Direct ophthalmoscopy, indirect ophthalmoscopy. That is the most important one. Thank you, Satish, for reminding. That is one of the. And the point here is that you should not be dilating it. That is another important thing. If you are dilating, you should document that, because the findings, if you are dilating and sending out, referring him out, you should be documenting that same. And the fundoscopy, what all things you will find? What was the fundoscopy finding here?
In fundus was normal, sir. There was no papilledema and maculas were normal and the optic nerve was also visualized, but it was appearing normal.
So CRVO, you have to know the different fundoscopy findings. Retinal hemorrhages, hypertensive changes. Here he is not a vitreous hemorrhage. How to differentiate each one of this? CRAVO.
CRAO, what is happening is there will be central retinal artery occlusion. As a result, what is happening is the macular area, that area will be appearing pale, and there will be the fovea area will be appearing more red. That is a cherry red spot will be there. And the nerves, because the nerves over that will not be seen much prominent, the fovea will be seen as prominent. So that will be
then CRVO.
CRVO, there will be redness present, sir.
Cattle truck appearance, you will see it in
CRVO.
Then
Detachment and all, we will be seeing that margin like shadow.
We will be able to see the detached retina. Ideally, what you have to do is that in ophthalmoscopy, in an emergency department, what type of ophthalmoscopy you will be able to do? You say direct or indirect?
Direct.
What is the one that you carry in your hand and do? That is direct or indirect ophthalmoscopy? Indirect ophthalmoscopy. Direct ophthalmoscopy, you need a magnifying lens and all those things. But that we don't routinely do. What we do is you just examine the fundus. What is you need to look for the retinal reflex from the back. You have to go around 30 centimeter behind from the patient. You need to ask the patient to look straight to the wall, and from there you start with the retinal reflex, and you should be explaining that you will be coming close to the patient, and from periphery to the center or center to the periphery. So whichever method teaching from periphery to center is the most common, but for a beginner it will be difficult. So you have to identify what you have to identify is the disc. So disc you have to practice this. It will a little time consuming process, but once you practice you will be able to easily do this. Okay. Fine.
And with this complaint, this patient was brought here.
Okay.
So systemic examination was normal. So we directly went to the ophthalmic examination, and ophthalmic, as we discussed earlier, everything was normal in that. So and he was giving a
everything was not normal except for the pupillary reflex was not there. So that is a very important finding. Bilaterally absent pupillary reflex. What will be the another reason for absent pupillary reflex in an elderly patient that is coming to you?
Post-surgery,
post-cataract surgery, again one, and diabetes. Again, one oculomotor nerve can be affected. So, diabetes is one reason because not for this patient. Very commonly, we can have diabetes patient coming with, and we don't have a very good pupillary reflex, or maybe even absent pupillary reflex also.
We took it as an autoimmune or a vasculitic condition.
So, as per the history, we don't have any history of any ingestion or anything. Sudden visual loss for a young male, unless and otherwise, we have to think in terms of probably an autoimmune pathology, a vasculitis, or a sudden multiple sclerosis, multiple bilateral visual loss. We need to take into that consideration. So, what was done for him? And he was completely evaluated for all those things, and it was found to be normal.
But since
MRI was done,
it was normal. So since he was having this vision loss, he felt guilty and he told the real history that he consumed 500 ml of a sanitizer 3 days back. He consumed that and he was totally asymptomatic and he was feeling sleepy and he slept. Next day morning he had multiple episodes of vomiting, following which he was taken to an outside hospital, managed symptomatically, but then also he didn't reveal the truth. Then towards that day evening he felt blurring of vision, and within 5 to 6 hours he had complete vision loss, and that was the real history of this patient.
Okay.
So it is a sanitizer overdose case. So we should...
Sanitizer overdose? Sanitizer should not contain methanol. It should not have methanol. It should be what is ideally the sanitizer should be made of.
Alcohol, ethyl alcohol
Ethyl
and
alcohol.
isopropyl alcohol, some amount.
Okay, but it was some adulteration has
Adulterated.
happened and it was mixed with methanol.
Methanol.
So toxicology was sent for him.
Sir, initially toxicology analysis, his blood and urine was sent. It was showing only alcohol content in it. Ethanol content was only present in that.
Okay.
And methanol was not detected in that.
Okay.
So, but we still suspected methanol.
What could be the reason here? Why it was not the toxicology didn't reveal anything?
Methanol will be excreted within 14 to 48 hours.
It will be
So,
metabolized, so it will be very difficult to get, and in the initial presentation only we will be able to get. Okay. Now coming to methanol, so it is clear cut now a methanol toxicity because it is clear cut bilateral it is involved, bilateral optic nerve is involved. So now it has come to methanol toxicity. Fine.
Any other investigations you did? Like
Visual.
then we have to check.
LP study was also done.
Which one?
LP was also done.
LP, yeah.
Was also done.
Before knowing this history.
Before
What
Because
so,
LP study was like normal, basically to rule out this NMO receptor defect and all. LP study.
NMO receptor, it was done and it was found to be normal. Fine.
Multiple sclerosis.
So we have ruled out a central nervous system issue. There was no vasculitis. There was no evidence of any other autoimmune diseases. So, and again, later on he revealed the history that he has consumed. So it came back to a methanol toxicity, and we had actually sent the sample
We
for
got
analysis.
the sanitizer bottle, then we sent for the analysis, and that was containing methanol levels were detected in the sanitizer solution.
Now,
okay. And especially with this COVID times, I mean, even CDC had come out with a notification saying that there was a pandemic kind of thing. Because initially people thought that we can wash hands, so why not drink sanitizer? And there was a lot of more like another pandemic because of the methanol thing itself reported. So in those scenarios, how do you deal if there is a lot of patients coming in at the same point, like a mass disaster kind of scenario?
So mass casualty by definition means if there are more than 3 patients presenting to the ER within 72 hours with vision loss complaint, that is called as a mass casualty. So patients either they might have consumed only ethanol or ethanol with methanol or methanol only.
usually what will happen, it will be adulterated. It will be ethanol and methanol, it will be a mixture of things, or maybe for some other reason accidentally they can ingest methanol also. So both methanol, as you said, methanol and combination can happen. Now you need to differentiate these 3. So you have 10 patients in front of you. How will you deal with them?
If the patient is having some features like increased talkativeness or meiosis is there, or agitated behavior is there, ataxia is there, mostly it can be because of an ethanol. And in case of methanol, they will be
Visual loss also will not be there in
Vision loss
ethanol.
will not be there.
That is the key thing. There is no visual loss that we classify into ethanol group. Then next.
Methanol, there can be tachypnea, altered behavior, seizures can be there, and metabolic pattern of breathing. Mydriasis will be there, and vision loss will be there. And if it is a mixture of both, it will be an adulterated alcohol, methanol with ethanol.
Then what else you have to do?
Then we have to check for the anion gap, and also initially what is happening in methanol, first the osmolar gap will increase, then the anion gap will be increasing. So based on that we have to decide on the treatment.
Okay.
So first
now let's see, we have for this patient there is nothing much to offer because there is no evidence of metabolic acidosis. There is level was never detected, so the role of antidote, everything is out. So only thing is that something to improve here vision, we can try it. Ethyl prednisolone, again it is not much of an evidences, but there is only case reports with erythropoietin and this thing. There are some case report, and we had couple of patients who had a little bit improvement in their vision. So after giving erythropoietin, so we have tried. So nothing more to offer for this patient as such. Now coming to methanol toxicity, a mixture of methanol versus ethanol or ethanol again. So how will you manage them? That we can discuss now.
We will manage according to airway breathing circulation, sir. And if the patient is having this acidotic breathing with features of metabolic acidosis, we have to treat with bicarbonates. So initially we will be starting as 1 to 2 milliequivalents per kg. We will be giving as a bolus, followed by infusion 132 milliequivalents in 1 liter of D5 water. We will be giving over 200.
Talking about bicarbonate.
200 250 to 200 to 250 ml per hour we will
Okay.
be giving. Then the treatment as such, we have to inhibit the alcohol dehydrogenase. For that we have to either give ethanol, but more preferable drug is fomepizole. If it is available, we have to give fomepizole. And the fomepizole dose is coming as 15 mg per kg dose we will be giving over 30 minutes, followed by 10 mg per kg we will be continuing. And if we are not having fomepizole, then we will have to give ethanol IV or oral we have to give. So IV, when we are giving, it is 10% ethanol we should be given. 10 ml per kg should be given bolus.
Okay. So
1 ml.
Fine. That's okay, because giving IV distilled spirit we have never practiced. Again, fomepizole is not available also. The practical thing that is going to possible is to give oral alcoholic beverage. How much you want to give?
That is 80 proof liquor we have to give. 1 ounce we have to give stat. Then every hourly we have to give 1 to 2 ounce we have to give every
Simple
hourly.
thing, you can ask them to drink 100 to 120 ml of distilled whatever spirit is available, whether it is rum, whatever brandy, whatever is available. 100 to 120 ml of distilled spirit you can ask them to drink. So whatever the excess methanol is there, it will be utilized. So fomepizole is again not available, but again in some area they are telling that it is available, but we haven't used fomepizole. And even IV distilled spirit we don't have experience in giving IV ethanol also. So
Target ethanol concentration we have to give between 100 to 150 so that the methanol will not be metabolized to formic acid.
So what are the indication to give fomepizole? Do all patients need this fomepizole or like this ethanol therapy?
No, sir. Depending on the patient's presentation, and that means depending on acidosis, pH less than 7.3, or if we are getting a sudden report that the methanol level is more than 20 and all, then only we will be given. Usually we will not be getting that much faster report.
So when you get a patient with methanol toxicity as such, the basic, you stabilize the airway breathing circulation, then you send the basic investigation is the blood gas analysis and electrolytes and your osmolar gap. And once you get the osmolar gap, renal function test obviously, and depending upon the toxicological methanol level and the acidosis and other manifestation, we will decide regarding the either fomepizole therapy, that is more theoretically, but what you can give, you can ask them to drink an ethanol of 100 to 125 ml of ethanol and still dialysis. That will be the other option. Okay. So what happened to this patient? He had visual loss.
He had vision loss and he was not having any acidosis or anything. Already the methanol was excreted from him, was excreted out, and there was no toxicological levels of ethanol in his body. So already the toxic manifestation has already happened, and he's in that state.
So what is the reason for the visual loss? Which acid is causing that?
Methanol formic acid is causing that. That will be causing toxic optic nerve degeneration will be happening. And we are giving a trial of erythropoietin for him so that erythropoietin can regenerate and can reduce the inflammation of the optic nerve.
So
Any improvement?
He was not having any perception of light, but the vision slightly improved that so that he can see some finger movements.
Any more thing in the management, though not in purely with emergency medicine point of view, but
Stem cell.
no.
Vitamin supplementation.
Basically, for the patient to, you have to always remember about visual
EMR
rehabilitation. Okay.
So we had discussed regarding the acute visual loss. So acute visual loss presentation to the ED, painless or painful visual loss, unilateral, bilateral, depending upon that basic clinical examination. We don't need an exhaustive ophthalmology evaluation, but with simple pupillar reflex, simple fundus examination, we will be able to come to a differential diagnosis.
Okay. Fine.
Thank you.